Greetings, everyone. Good afternoon to one and all. Welcome to the third academic session of Study Club of POPMA. POPMA is Practicing Oral Pathologists and Microbiologists Association. It's a national level organization of practicing oral pathologists. Practicing means either institutional or private practice, and the sole aim of POPMA is to promote the specialty practice of oral pathology. I am Dr. Bhuvan Nagpal and I welcome you all on behalf of POPMA. Today we have a special guest who will be talking on a special topic which he will reveal by himself. I'll just introduce my good friend, Dr. Abhishek Banerjee. Dr. Abhishek Banerjee is a postgraduate in oral pathology, and he's the PhD scholar at National Institute of Technology, Durgapur, and that is a DBT research scholar. He is consultant oral oncopathologist at the Practice of Oral and Maxillofacial Pathology, Durgapur, which is his lab cum oral disease diagnosis facility. He is also associate professor and PG guide in the Department of Oral Pathology at Awadh Dental College and Hospital, Jamshedpur. He is also adjunct professor in the Department of Oral Pathology and Diagnosis at Universities Erlangga, Indonesia. He is also editor-in-chief of Oral Health Bulletin IDA Durgapur Publications. He has a H index of 4 and has 46 publications to his credit. He is a reviewer of FID, SJOS, BMC, BMJ, Wiley, and CCR. And apart from that, he is a very good clinician and an awesome and brilliant oral pathologist, and always ready to think beyond the conventional. So I welcome Dr. Abhishek to our talk event, which we conduct every 2 months. And now over to you, sir. Thank you so much.
Thank you, Dr. Bhuvan. And you have given a big flaunting introduction of mine. Everything minimized to I am oral pathologist by profession and by passion. I love oral pathology and I love people who practice oral pathology after pursuing their degree in oral pathology. And I'm always ready to get help, share help, and discuss things and learn things from all oral pathologists across.
Dr. Abhishek, you have been muted. Yes. Sorry for the interruption. Please go ahead.
1 minute.
Yes. Yeah, it was on mute. Please go ahead with it. Now it is unmuted. Please.
Yeah, fine. Now it's okay? Everyone can see this? Okay.
Yes.
So thank you, POPMA, the Practicing Oral Pathologists and Microbiologists Association. This is a national level oral pathology association practicing people who are there in this as member. And I'm very happy to share that they have given me a chance of conducting the third study club, that is using their eye to seek diagnostic information. And it is very interesting and a very difficult topic simultaneously, and it's why I feel like this topic is very important, because this is the topic where it was a nightmare for me when a big sample has come to my practice and I have no clue where to start with this reporting, because I have finished my MDS and I have never been exposed to all these things during my entire PG time. And this is not only with me, this is with many people who don't know what is basic of grossing. And here, this time, Dr. Kabita Chatterjee, ma'am, professor and ex-head of oral and maxillofacial pathology, Buddha Institute of Dental Sciences, Patna, who came to my rescue over telephone. She has explained me the basics of the grossing over telephone, and she has given me few materials also where I should refer. And over a period of time, gradually, it is a learning process where I have learned a bit of the topic, and I am little bit competent in delivering the cancer reports. So that I will be sharing what all are the important things while doing grossing. So grossing, the terms refer to the detailed examination and the systemic dissection of surgical specimens in order to obtain the tissue sections which felicitate the microscopic examination. It is the first step of dissection procedure of a surgical pathology specimen. So it means it is a systematic dissection of a surgical specimen. Means there should be an order in how we should obtain tissue sections, and simultaneously which facilitate the microscopic examination. It is a detailed dissection procedure of how a surgical pathology specimen should be carried out. So there's a quotation which I have found, that I have 5 good friends: why, what, how, when, and where. And they taught me all I need to know. The few important things which are very important, that is the biopsy triage. Biopsy triage means we have to know what are the things which are very important for entering into the biopsy room or entering into the biopsy facility. There should be a proper designated grossing room or a table, grossing tools, and the most important is the grossing personals. Grossing personals, involve you personally, who is the person who is involved in the grossing, a person who can take down the notes, a person who can help down in your grossing, and all these things make the total thing of a biopsy triage. And it is always wrong that everywhere and for everyone, anyone to believe anything on insufficient evidence. So it is saying that everywhere we have to believe where there is a sufficient evidence. We should not go with something which has insufficient evidence. And oral pathology is something like Sherlock Holmes stories. And as a rule, specimen containers employed for the patient should have firmly attached with a label relevant patient's data, and followed by also the time of the procedure when it was performed and the other details like the solution and everything. So this is a pictorial which is I have taken multiple things from many PPTs, many articles, many PDFs. So if there is anything which is resemblance, don't take me wrong. It is only for knowledge sharing purpose. Nothing to put me great or something like that. These are not my pictures, but these are good pictures. So this is something like which we have to tell that the specimen received was how it was in a formalin or in a saline or in what way, and whether it was adequate or whether it was inadequate or not. The requirements for the grossing room requires the ruler with the millimeter scale, magnifying lens, waste bin shafts, container, disinfectant, weighing scale, measuring cylinder, and pencil, pens, etc., grossing ink. Out of this, the ruler is a very important thing, magnifying lens. You can always, so for small specimens also, or section specimens, you can also use a stereo microscope if you can buy that. Then you have to keep sharps. Then you have to keep a measuring cylinder. Camera for photography is very, very important. Pencil and pens for labeling the cassettes. Always use a pencil for labeling the your cassettes. with a small chit of paper, tissue cassettes, and grossing ink. I will be discussing about grossing ink in detail in the next few slides. Okay. So other things which are also important, that is the fume extractor, surgical blades and scalpels, grossing knife for and also the round wheel cutter for the bones. There are different things which you can have. It is available even in the market. So this is a picture. Again, it is absorbed from the web. This is how a grossing room should look like with the notes and everything. They should have a sink on the extreme sides. There's a table. And sometimes I have seen even grossing tables that are slopy. So this is how the samples should be kept. And these are ink specimens. So the orientation of the blocks is enhanced by a sponge, securing the specimens in a sequential position. This is a sponge. Those all things are practically, it is not that very possible. But yes, definitely you can click a photograph also, and you can communicate with your technician, and you can also be there while there during the embedding time. These cassettes are overloaded, so you can see how this the overloading happen. These are also overloaded cassettes, so it should be adequate so that the medium flows very well. And these are the ineligible cassette levels are totally unacceptable. See how many times this labeling has been done. So always use a new thing. So if you want these cassettes and all, these are freely available in the market and is in the web also, and it costs very less. For 100 it costs around, I think the per box it contains as 2 rupees or something like that. So we should not be miser in all such things, and we should use all the new things, because sometimes the old specimen samples, tit and bits are also left in those cassettes. So this is the sample orientation which we can get from the surgeon, and is a knot. So this knot actually specifies the direction and the orientation of the sample. We should always take a ruler, and we should damp it, and we should take a photograph for orientation. This is how this ink has been given, different inks to actually mark the orientation of that, and thus can be clearly seen. The purpose of inking during the grossing is to determine the margins of the specimen. That is the most important. To indicate the specific areas of interest, that also you can do. If there is any specific interest areas, to indicate the mode, of embedding, the maintaining the anatomic orientation of the specimen. Inks of different colors designated each of 6 specimen margins. There's the superior, inferior, medial, lateral, and anterior and posterior. That can be also done. So anatomic orientation and specific areas and the mode of embedding, these all are the purpose for inking. Note, inking cut surface of the tissue on one color will help in embedding to determine whether the surface should be embedded down. Ink surface will meet the blade in the first go during the microtomy process, and it is typically reserved for excision specimens, not usually recorded for second procedures and separated based on the diagnosis of the biopsy. This is how we can damp using, these are the very thin blotting papers that we can use during the formalin fixation. This is how this is a very big, these are usually the breast specimens, and but during our tumors, which we get very big tumors and all, we can usually do like this, very thin 4 mm or 5 mm slices we can, and we can see the entire lesion in one go. Now consistency and color, these are very important. Now this color interpretation, there's white calcification with the bone, gray with the white fibrosis, invasion of the lymph node, yellow with the lipoma, the fat necrosis, brown with the melanin, red with the hemorrhage and the vessel congestion, and the different consistencies and the interpretation that can be seen as soft necrosis with the fluid, firm with the fibrosis, hard with the bone and calcification, rubber with the lymph nodes, cheesy keratin for specific odontogenic and cystic lesions, cacheating necrosis. So these are the different consistency with how we can describe and we can communicate with the surgeon. Surgeons do not need your flowery diagnosis, but surgeons need what they can do with your diagnosis, what with that they can help your patient. So we need to know about all these things. Even we can explain to the surgeon with our own flowery language also that this is this, this is that. That also will help the surgeon or the clinician to give a good accurate diagnosis, means a good accurate treatment plan and all. Now inking. Preferably apply to the dye, to the unfixed specimen, pat the fresh tissues dry with the paper towels, what I have already shown, and sometimes do not cut on the wet ink. So this is how the inking and this how it looks in the histopathology. So what colors you actually should in India ink is the ideal choice, but if you do not get that in your local areas or somewhere, you can use this Fevicryl Hobby colors. This is the acrylic colors you can use. You can use a brush and you can slowly you can paint the surface. When you are using that, make sure your hands or your gloves are very clear, clean, so that you do not put colors into the other areas where you are not supposed to put. Extra dab with such as acetic acid 5% in 3 to 450% of white vinegar also, which accelerates the drying process. So once you put the color, then you can probably with in a tissue paper, very thin tissue paper, or a cloth, or a small flat vessel, you can put this solution, and you can just slightly you can press over there so that it dries very fast and it don't smudge everywhere. Our motto of this presentation is overall that all specimens, even of the same type, are unique. And this is particularly true for head and neck specimen. Thus, this outline is meant to provide a guide to grossing of the head and neck specimen. In this particular seminar, we are going to describe about the malignant neoplasm, the OSCC, in detail, how and what are the important things to be written in the report. For that, you can refer to AGCC 8, you can refer to CAP, you can refer to different universities. And but it is of always preferable that when there is nothing, you can follow a particular protocol and you can mention according to this protocol is there. So in my practice, usually the CAP protocol is sufficient enough to give the detail of the reporting, and it is like a MCQ based. So you just have to fill up those points. So you do write that and your surgeon will know what they want. So coming on with the first, that is a margin, that is a specimen derived margin. A margin that take directly from the main specimen, either from the shave or radial. Tumor bed margin is one piece that is from the name itself, tumor bed. Bed in what we sleep. So the tumor is sleeping on the bed. So that particular area is where we want to see whether the tumor is there or not. And note to the grosser that even if surgeon submits the tumor bed separately, the grosser must still sample the specimen margin. You should not leave any specimen margin unexamined. Whether he has given or whether he has not given, if he has given, mention everything. Everything is there in the CAP protocol. So once my talk is over, I will give all the notes in the group. You can give your viewpoints. It will be a good learning session for me also, because I am not a very old practitioner. There are many people who are practicing since many days, so they can give also the best inputs from their side. Radial margin allows a measurement of exact distance between the tumor and the margin. Few frozen versus permanent sampling issues easier to interpret, and representative tumor is directly available for the direct comparison with the atypical foci. Shave margin is the margin is examined microscopically, but remember the word that is the greater margin area. Now see, these are the red lines, the radial sections, these are the perpendicular sections which are there. And blue line, this is the shave of the margin. So the shave of the margin gives a very big area for study, but it will The red line it can give the how far or how near is the tumor margin, whether it is clear or not, all this. And this particular sutures are for the orientation. This is one more photograph taken from one of the publications from MS Ramaiah Dental College. Very good review article. I will give that in the group too. And it's tells this is how the potato, with the potato, they have done this schematic, this thing. They have first aimed at this is the tumor portion, and this is how they have taken out. So this is the lesion proper, this is the margin, and this is the normal tissue. So these methods of obtaining a horizontal and the vertical margin. So what they tell, this horizontal margin allows the examination and the vertical margin gives the distance of the clearance. So once you actually do a hands-on, you will understand it is very easy, but you need to do a hands-on for this grossing. Then you will understand more better. But previous to that, this theory portion should be very clear, like what you are going to do with the specimen. Not just cut abruptly from here and there, because that will actually destroy the specimen. Now, partial glossectomy with a portion of mandible, what need to be done? Then make a note of both and describe if mobile or tip or the non-mobile base of the tongue. So what they're telling about the orientation. They're telling about the location of the entire thing. Access the presence of the floor of the mouth, sublingual gland and attached gingiva and attached tonsil and describe accordingly. Sometimes the surgeon, what they will do, they will take out the entire specimen for you, will gift it to you, but on a separate piece of bottle. After the surgery, probably when they were suturing or something, they found a small proliferative growth. Now they cannot again do the entire thing. So what they will do, they will take a wider margin and they will submit the sample separately. So that sample should be given as a separate or a note report that see this is clear or not, and this is how far, this is how close to the tumor margin. And this will help them to do a very good neat follow-up because that will be written in your report. And next is don't describe the margins in terms of inferior or lateral. Sometimes we do that, but it is always, if you are writing inferior or lateral also, you can write lateral towards the buccal mucosa, inferior towards the floor of the mouth. That will help them to know much more better about your report. Your overall aim is to communicate through a written format. Next is always measure the depth of invasion and include a section to document the deepest extension of the invasion, as this is the critical stage element for oral cavity carcinoma. If the margin is far from the tumor, that is, can shave. If close, take a radial or perpendicular. But it is always advised, I do in my practice, try to take both the things. It helps me a lot. So 5 mm you can take as a your own index, and you can mention 5 mm from this, 5 mm from the. So this can help you more in giving your report like a story, and document the size of the tumor and what structure it involved, whether it is involving any crucial structure, floor of the mouth, base, and anything. Margins include the floor of the mouth, deep tongue, more along the underside of the tongue, and other posterior, superior, some cases also the gingival, retromolar, trigon, tonsillar, and everything. So you, when you are orienting, you should imagine the whole oral cavity, how it was in the oral cavity. And in QClan, even revise it with the help of your grossing personnel, your friend or your junior, whoever. So this is how sample. This is the tumor, and this is the tumor. This is the floor of the tongue. This superior, and this is the medial. See, this is the taken. This is the deep area which is taken. So this was actually the lesion which was there, and beneath this is the floor of the mouth. So this is the anterior, and this is posterior. This is how the orientation should be done. And see, this is obtained from the surgical pathology clinics. This is a hemiglossectomy specimen. So these all things are very important guide. You can make a book and keep it in your clinic. You can read whenever you are free. This can help you a very good way. And to all the postgraduates who are initially starting off with the practice, try inculcating a habit of reading articles and reading about what you are going to do, what you are going to see, what you are thinking about. So describe the type of specimen, ink the specimen, locate the tumor in the accurate and anatomical site, and measure the tumor in the 2 dimensions on the mucosal surface. So this is how, again, the orientation. See, the tongue is divided into left lateral, right lateral, mucosal margin, posterior mucosal margin. So these all are the things which you can actually do. So sections should include approximately 3 sections of the tumor, but you can go for more. Then you can consider the negative margin, that is the 5 mm. So this is not, this is more than 5 mm. But yes, you can make a note of exactly the dimension, and that is also mentioned in the CAP protocol. And keep in mind while accessing, describing, and selecting the best areas of the section to demonstrate the margins for this. So what you clinically you see with your eyes or through your lens, you try to incorporate that in your report. And must also know to include the statement describing if the tumor appears to be grossly involving the mandibular bone, and a section must be taken in the bone in relation to the tumor. The moment the bone is involved, it is T4. That is also mentioned in your CRAP protocol. So if you read the entire CRAP protocol, this seminar presentation is very lucid. Remember, any tumor adjacent to the involved bone, if a part of the tumor is soft and does not need decalcification, please isolate 1 or 2 sections and submit it as non-decalcified tumor. But if there are some decalcification, I will deal again in the later part of this seminar, how to deal with the decalcified portions of the tumor. Now, types of mandibulectomies. You should know what are the types, what sample is submitted to you, whether it is a marginal, whether it is a segmental. So this is a marginal, a portion of this which has been taken, prophylactically they have removed, and this is a segmental that has involved the tumor. So this is how the orientation has been done. This is from the lingual aspect. This is how the tumors this can be grossed. And this is how the soft tissue is attached to your specimen, and you need to gross like this in the radial. This triage I have already told, and orienting all the specimen in the anterior, posterior, superior, inferior. Think before you ink. If the specimen is very small, fix in the formalin overnight. If the large you want to section and you want to penetrate, you can go ahead with that also. Decision is all yours. Now, going ahead with the decalcification, many times I do get a call from many pathologists like, what you actually use Dada for doing like this? Now, I tell them always try, if you have taken a good amount of time from your surgeon. Few surgeons, they will annoying you like anything. Give me the report, give me the report, give me the report. Thing is, like, you cannot make the biryani in half an hour. Biryani will need a definite amount of time. So you ask for the time. But in case if you have a very rapid report, there is a bone or whether it is a calcified mass, you can shift to nitric. But remember, there also you have to be very cautious, because that usually that disturbs the architecture histological features. So always try with the formic acid, formalin, that is 10% formic acid in 10 ml, distilled water 85, and 40% of formaldehyde in 5. So this you can keep it in overnight, and every time you take a very sharp instrument and just prick it twice daily from after 2 days, and you can gradually see what it can be. But if in a small piece of tissue, you can see that there is a small bit of calcification. Obviously, you cannot go for the entire decalcification. So what you can do, you can spot decalcify it with the nitric acid and you can go ahead. Tissues like tracheal margins and pinna of the ear requires a mild decalcification. You can imagine how those tracheal margins and all these are very kind of a very flexible kind of a bone. So you can put in the 10% of buffer formalin and nitric acid for simultaneous fixation, and then you can decalcify with the 5% of nitric acid for 5 to 6 hours. Tissues retained in the nitric acid solutions for a longer period if there is no more need of this, and you should at least check for twice a day. And after achieving the decalcification, the tissue should be continuously rinsed with the running tap water 30 minutes for small, 3 to 4 hours for a big. So running in the tap water is very, very important. And once after that, we need to put in a 70% of alcohol, and then we should go ahead. So these all are the things. This starts from the grossing. This is not a part of the processing. So this all things you should keep in mind, that this all chemicals should be there in front of you. So you should not start and you should rush for the chemicals here and there. And soft tissue margin and bone cut tissues. These are I have shown in the previous slides. Photographs of the cut sections should be very clear and prior to the decalcification in order to orient. We recommend you to cut your sections first with the bone saw and then decalcification into thin. But sometimes it is difficult, so you can do the otherwise also. I have tried, it is not that bad. So this is how a schematic diagram is again shown. This is the oral epithelium, lateral margin, deep margin. This is how the deep. So you need to see everywhere. And below this is the bed. The sections to be submitted, that is a tumor, that is a margin, that is the decalcified bone section, skin, and the soft tissue margins. So this is how you should orient. This is how you should photograph. This is how we should ink medial, lateral, see buccal and cheek margin, lingual gingiva and floor of the mouth. So these are the things how you can elaborate, and you can keep these photographs with you for while reporting composite. Next is how the big specimen should be done. This is how the suture orientation has been done. This is how the small specimen is done. This is not quite this is theoretical. Sometimes it is not practically possible. But yes, if we at least try to follow 50% of this, we will be in a pretty good position for the reporting. Now, essential data that to be incorporated in the histopathology report for the squamous cell carcinoma of the oral cavity. There's a type of the surgery and specimen, tumor dimension, type of cancer, tumor grade, and grading as independent factor does not correlate with the prognosis. Next very important topic is the pattern of the invasive font. Pattern of the invasive font, that is, it determines the stage, and the pattern is assessed at the invasive font of the tumor, that is at the tumor stroma interface. A cohesive font is associated with a better compared to a non-cohesive. And cohesive invasion defined as a tumor nest more than 15 cells across. The non-cohesive cells can include strands, small groups of 15, less than 15 cells, single infiltrating tumor cells. So this is very common thing. Non-cohesive means more spreading. Cohesive means taking less time. So it will affect the prognosis. So there are 5 patterns of invasion. That is the type 1, pushing border, type 2, finger-like growth, type 3, separate large, type 4, small tumor island, 15 cells or less per island, type 5 is tumor satellite, equal or greater than 1 mm away from the main tumor. This is very important. And to simplify this, that the recommendation as of now to report whether worst pattern of invasion 5 is present or not. Surgeon will only want this type 5 or rest 1 to 4 is there or not. So this is very important. We need to see for the diagrams like this. So this is A, that is the low power of overview demonstrating the generalized tumor dispersion. The tumor is still here. The carcinoma satellites in the green box are shown in. So this is the carcinoma, this thing. And this is the B, that is the lower edge. See how far is the distance that is measured through the auto image analyzer, or you can measure through this ruler. You can measure through the objective ruler and fulfilling the worst pattern of 5. And this carcinoma reveals that the rare dispersed satellite fulfilling this criteria likely due to the extratumoral lymphovascular emboli. So this has spread due to the lymphovascular emboli. So this is how we should measure the distance, and we should classify the worst pattern of invasion. So this is one more schematic diagram which I found in the Instagram, and this is how the non-aggressive is the 1 to 3 and 4, 5 is little aggressive. And this is how, see, the spread, it is still not broad pushing. This is how it is more, this is more, and this is how far 1 mm or more it is spread. Next is a very important thing, that is the depth of invasion. This depth of invasion in the oral cavity is an essential part of this prognostic indicator, and it is well mentioned in the AJC. And it is incorporated that it is also involved in determining the T stage. So it measures the invasiveness of the carcinoma, and hence it will be different for an exophytic and an endophytic tumor. Now, it is usually mentioned from the vertical, or a plumb line extends to the deepest part of the tumor, and it usually represents the DOI. It always from the basement membrane to the deepest part of the tumor, and it is tried to extrapolate to an area where it is a comparatively straight. It is usually a straight line which is drawn. But when we compare an exophytic tumor or an ulceroproliferative tumor, the ulceroproliferative tumor may be thin. So we have to go with that exophytic one. We have to go from the basement membrane, and we have to go till that. So, but the DOI is more, and hence associated with the bad prognosis. Though the DOI is more in this case, but it is still, we have to mention, it is a ulcerative is this thickness. So it represents a bad. So it is important to understand that the tumor thickness and the tumor DOI are different and non-synonymous. Tumor thickness is the total thickness from the top till the end of the tumor has spread. But DOI is from the basement membrane. So DOI increases with the staging and one step for every 5 mm, and DOI is reported in millimeters. So this is how a horizon of the adjacent basement membrane. See, this is from the basement membrane till here. So this is a vertical plumb line it is drawn. So depth of invasion is the horizontal line established. First one horizontal line, from here a vertical line till the deepest point. So the greatest DOI represents the plumb line from the horizon. This is one ulcerative age which was I was talking about, and it is note how tumor thickness would be deceptively thinner than the DOI. So tumor thickness will be from here be like less compared to the DOI, but this having a poor prognosis. Next is the perineural invasion. Perineural means the perineurium. So the tumor should wrap the perineurium. Entrapped nerve bundles would be the involvement of the perineurium, should not be reported as PNI. This is critical because presence of perineural invasion, patient will receive radiotherapy, and there are instances when the other adverse factors are also present in a particular case. But what I have found from the surgeons, good surgeons also, usually based on the T4 and the staging, they go for, even if there are no PNI, they go for a radiotherapy at some instance. So the size of the nerve bundle is also involved, whether it is less than 1 mm or whether it is more than 1 mm. Also the location of the PNI, that is whether it is away from the tumor proper or whether within the tumor proper, is appeared to be having a role in determining the outcome. So it's the more distantly spread, that means it is more bad. If it is the tumor is within a big trunk, that is also bad. So these all are the different factors that we have to feel during seeing the sections. So this is the schematic diagram. This is a nerve. This is how the trunk it is involving. And see, this is how the nerve trunk, and this is how the perineural invasion is. The cancer cell. This is a independent nerve trunk. And this is how also one more it is seen. This is a lymphovascular invasion that can be seen. So lymphovascular invasion is also indicator of a bad prognosis. It identifies by a demonstration of a malignant cell within the lumina of the blood vessels. From the word itself, lymphovascular, we can see. And in some difficult case where we cannot exactly tell whether it is an endothelial cell proliferation or whether it is a this thing, we can go ahead with the IHC. Lymph nodes. This is a very important thing because you can go for a very selective lymph node dissection. We can go for a total R&D. And there, measurement of this tumor metastasis, the cross-sectional dimension of this largest lymph node metastasis lymph node is very important. So you have to actually cherry pick those lymph nodes from the fibrofatty tissues that has been submitted to you. You have to see whether how is the consistency. Do not press it too hard, but use a very gentle bidigital pressure to see how is the consistency. Already I have mentioned that it is a rubbery consistency. So you have to press and you have to feel about that. So sometimes you see that is the capsule has been ruptured. So there you have to photograph. You have to mention that this is the biggest. This was looking like this. This was looking like necrotic. So this is the how you should examine a lymph node. This is how the sections you have to submit for the lymph node. Number of lymph node is very important. You have to always find out that how many lymph nodes have been submitted. Try to give the large, all the lymph nodes what has been given. Do not do any conjuicy. Do not think how many more blocks you have to pay, but submit the even the smallest of the lymph nodes. Please take it out and do sections and submit it. If there are, if you can feel multiple small are there, give it in the same cassette and mention according to the different levels of the neck. Is it involving with the gland? So this all carries a very important. So in oral cavity, a minimal of adequate dissection of 18 lymph nodes had been proposed, but yet not validated. But what I feel surgeons feels very good if you give a good amount of lymph nodes. So obviously one single lymph node will count one, but you can see sometimes you can feel, okay, these are two, but in the histological sections you can see that, okay, no, this is not two, this is one, it was looking like little depression in the center. So you can approximate and you can also write down the count in your grossing record and after your reporting also. So this examination of a fewer tumor free node still mandates the PN0 designation. So all macroscopically negative and equal volume should be submitted in toto, what I have told, and we have to also look for extranodal extension. So first there is a central connection with what they will first come to the lymph node. Then after that they will spread to the extranodal. Extranodal means they can also go for the body spaces. So that is having a very poor spread. So that is having a very poor outcome. So that we have to mention. We have to submit. We have to see the capsule of the lymph node also. So before going on with this lymph node dissection, we should study the lymph node also. So histology is very important for this. Sometimes what happens, there are a lot of fibrosis which happens because of the long-standing chronic inflammation. That can actually mimic the metastatic means keratin pulp. But when you actually see in a larger this thing, larger magnification, you can see there are a lot of fibroblasts and all this. So this is how you can actually do the troubleshooting. So this is my end of this presentation with a lot of things that focuses on what are the things you should keep in the grossing, what are the things you should keep in the mind, what you should read, what is your standard protocol, and how you should go from A to Z. And do not be panic when you get a bigger specimen. When a big surgeon sends you, you should not get panic. Your report is unique. You are an oral pathologist. That knowledge he does not have. So be have confidence in your record, have confidence in your reporting. But yes, do read before reporting. If you want to know, keep revising. And that's all about my presentation. Thank you so much for giving me this opportunity. I am well before on time and I expect all doubts from your side. Thank you so much.
Yes, that was an amazing presentation, Dr. Abhishek, and kudos to you. It was indeed a grossing presentation. You have actually grossed the presentation from.
Yeah, that's why I have kept a fork, because that fork and the knife first you should hold properly. So that is how you should hold your blade. You should know what are the blades. I have not gone in depth about the armamentarium. That is also a very important thing, because many times when I do not get my brush, I do not get this. So these are very important things. The used blades of your microtome you can use for your grossing. Those are very good things. You should not use that scalpel blade that usually we do for surgical. That usually
Yes.
get destroyed. And one more important thing is, like, I have taken a fork. That fork means exactly how much piece I want to take it out. So we have a good correlation with the instruments, with the notes, what we have. So we should all keep this in the mind, and every day is an improvement day. So more we get specimens, more we will learn, and we should thank the surgeons and the clinicians who are supporting us. Oral pathology is without nothing single-handedly. It is always a interdisciplinary association.
Yes, very, very much true. And yes, you have covered almost from all the hemiglossectomy specimens and going till the basics, starting from the basics till the higher end. And yes, that's a very true thing which you have mentioned, that we should never get panic if we get a bigger specimen. Thank you so much, Dr. Abhishek, for this wonderful presentation and accepting our invite to be on our study group. And yes, there are so many compliments for you by our participants. I must tell you that 77 people have registered and 28 people have attended. Uh, Many people are congratulating you, and it was indeed an informative lecture. And the podium is open for questions to the audience.
Hi, Dr. Bhuvan, Dr. Yovita
Yes,
here.
yes. Hi, Dr. Yoita sir.
I
Yes.
was
Yeah,
expecting something
Dr.
from sir.
Abhishek, thanks for that informative lecture.
Thank you, sir. Thank you.
Amazing, amazing. Congratulations. And I have only one doubt regarding this grossing. When
Yes.
we go about with the hard tissue grossing, when
Yes.
if it is like a maxillectomy or mandibulectomy, so how we have to deal with this hard tissue while doing the grossing? Because the soft tissue, there will be like suturing to anterior posterior border or pattern of invasion we can identify, but regarding this hard tissue, to identify the depth of invasion or depth of invasion in the bone, how to deal about it,
Sir,
even if it is squamous
actually,
cell carcinoma.
okay, sorry for interruption, sir. Sir, but one thing I want to mention: the moment you get a hard tissue sample with you, first
Yes,
we need to orient it. That is the number one for any specimen. We need
yes,
to see that how the soft tissue is attached. So now, generally, for example, if I am taking a palate, for
okay,
example, I'm taking a palate. We know
yes,
that there is a hemi maxillectomy done or complete maxillectomy. If complete, that is a very good thing. We can see the curvature of the palate and we can see the
yes,
soft tissue which is attached. Now,
yes,
what we can do, we can photograph. We can photograph and we can take a small soft tissue and keep it aside. Chalo, this is
okay,
from the medial side. Then we
okay,
can go for the lateral side. Now, the
okay,
bone which is kept with us, we have
okay,
to keep for decalcification.
yes,
We have no clue. For example, what we can do, what sometimes I do, I have orthodontic ligature wire with me,
okay,
because after decalcification we will have, sometimes we will have nothing, it will be only
yes,
just
yes,
a soft tissue. So that
true, true,
orthodontic ligature wire is a very thin wire. We can
okay,
just keep a tag into the anterior portion
great,
and we
great,
can keep
okay,
it for the decalcification. And moment that every day we are doing that sharp needle pricking, no. So that
yes,
time
yes,
we are seeing that whether it has become soft or not. The moment it has, the day we have soft, first thing we have to go to the closest approximation and without disturbing anything, just remove that. And
okay,
one more thing you were telling about the depth of invasion, the
yes,
if we actually look into the this thing cap protocol, the moment
okay,
the bone involvement is there, there is the depth of invasion has a very little role of significance, because it is already, it is in the highest stage. We have to
yes,
think it as very bad, because bone
okay,
has bone marrow, and bone marrow
yes,
means it has it can go to the any part, it can go for any metastasis and all. Also, it is locally very aggressive.
yes, yes.
So that,
Actually,
like that, we have to give the staging.
actually, I believe like somewhere I have read like 5 mm of bone has to be like it has to be trimmed for every 5 mm, the entire mandible. If they have done an hemimandibulectomy, so we have to cut that mandible for each 5 mm, and then we have to assess the invasion, like
Sir,
whether.
actually, yours. This is the very correct thing. That I also
Yes,
said.
yes,
In one slide, they have told for a soft tissue, we need every three sections from the main tumor bit.
yes,
But
yes,
thing is like for bone also, if we can submit the entire thing, that is very good. But
yes,
thing is like for the bone, we will in the soft tissue. At least we are seeing through our eyes. In
yes.
the bone, we cannot know now till which extent it has gone. So
That's what. That's what.
it is very advisable to go for the entire 5 mm, 5 mm, 5 mm. We have to go.
Yeah,
If
yeah,
lesser than that also we can go. That is more than good. But
yeah.
thing
But
is like in private practice, the patient will
exactly.
give a very limited amount of money sometimes,
Yes,
and we have to suffice that because very big long sections we have to give.
yeah,
Because normally if we do with the lymph nodes and all, it goes up to 23 to 25 also. So
yes, yes.
sometimes surgeons also tell that my patient cannot pay this much, my patient cannot pay because it comes directly from the hospital.
True,
So
true.
there we have to take our own call that which area it is our more interest. But
Yes,
for academic purpose of view, I will tell the entire section should be submitted. Even
yes,
fibrofatty tissues also should be submitted like 3 mm, 3 mm. Like it is also good, no? That
yes.
whether it is spread extra coelomic or not.
Yeah, because even in our academic institution, we find difficult to like do it in the cut section with the oxoblate. We cannot use
Mhm.
micromotor and this with the cut section. So we have
Sir,
to.
sir, there is one wheel if you will get in the hardware shop.
Okay.
For they usually
Yes,
cut those thin this
Yeah,
pipes, plastic
yes,
pipes.
yes, yes, yes,
Huh? So that is a handheld thing, but it
but
yes,
needs to be little careful because
more
this
care. Uh,
bone we have to first cut it. No, bone
yes,
will be very hard, so it can be very slippery also.
sure,
So
sure.
if there is a bigger thing, first I prefer that little slight decal should be done, and then the
then the slicing should be carried out.
Uh,
it is easy for us actually.
I just want to add one point regarding this topic, because most of the time when we are engaged with this huge specimen for grossing, what happens is accidents happen. Sometimes formalin may come and fall into the eyes. Those who are doing grossing, because so that proper like protective measures has
Yes, sir. Correct,
of
correct,
the time students will be doing it, postgraduate
correct,
students, or
correct,
sometimes beginners will be like they'll be starters
correct.
independently. They will be starting with their own pathology practice.
Yes, yes.
So I think the protective measures has to be
That is also need to be
carefully
added. Correct, sir.
taken.
Very true, very true, sir.
Yes. Thank you, thank you.
Thank you,
That's
sir. Thank you, sir.
really a great suggestion. We have one more question, Dr. Abhishek, from Dr. Arushi ma'am. She's asking, do we need to keep photographic evidence of gross for all the cases?
Actually, it is very advisable for yourself because there are always good and the bad people are always there. There are always good and bad people. Once I have submitted a photograph along with this histopathology, and my patient went to this thing, Prince Saleh Hospital, Mumbai, I think. And the main surgical pathologist and called me and told, "Do oral pathologists exist?" I told, "Yes, sir. I am an oral pathologist." No, excellent. How you are taught? Who teaches you all this thing? And as an oral pathologist only. So thing is like sometimes you will get appreciated. But usually if you see general pathologists sometimes report and all, their report is very concise. Sometimes they do not follow even the protocol. So photography is very important and even radiography is important.
Radiography is also
But
very
again, that radiography facility, I think only in the academic institution because that radiography things we won't get in our clinical this thing because we will have that small radiograph. So like that photography we should keep. That is for ourselves also because many times what happens, you get a serial of 2 3 samples. You remember one bone, okay, this is very important, but you forget to take the photography. So you can go back to the photography and you can actually correlate. That is also helpful.
And one more thing I would like to add as a medical legal consultant, that it's always better to have such evidences, because they can help us in the court of law to substantiate or to bystand our diagnosis. So there is no harm in keeping that evidence, provided you have that much time, that much storage, and so many other things. Yes, one more comment is there by Dr. Soundarya. She's saying, very informative session. Thank you, sir. And thank you, POPMA, for organizing such sessions. Looking forward for more in future. Thank you so much, Dr. Soundarya, for attending the session. And I think we are almost on the time. And before like wrapping up, I would like to ask one thing, that give some take home message like about writing the grossing description for the beginners, those who are the PG students or who are into the practice, because that also carries a good importance, because it's a part of our histopathology report. So please throw some light on that aspect. Dr. Abhishek?
Yes, I was just writing in the chat box. Can everyone, we can on the camera so that we can have a photograph, something like that.
Yes, we can have that. Yes, we all can have. If you can give some pointers for like writing the grossing description.
Grossing description.
That,
Grossing description is like the first thing we have to go for, again, step by step. ABC. You receive the grossing bottles. Like today, I received a grossing bottle. The moment I take out of the plastic, I see whether there is a note is there or not. Number one, that is the requisition form, like what the surgeon has performed, whether he has just sent that, or whether he has, if he has shared it through the WhatsApp, do print it and keep it in your requisition file. Next is, without opening the bottle, just take a photograph and see whether it is leaking or not. Many times do happen that it is a leaky bottles and all. Next is, once you open it up, you see there's adequate formalin is there, whether the specimen is good or not, whether there is any autolysis has happened or not. These are very important, because the second or third gross sample which I have received, it was totally autolyzed. Everything was yellow, yellow, yellow. So thing is like, I don't know, but somehow that may be bad or good. The main specimen I could give the report, but the lymph node I have just written something like diplomatically. I have to give something, but it was all autolyzed things which was there. So after that, we have to keep a ruler that we have to for the measurement. We have to keep measuring all the things, and we have to see the consistency, color, what I have already mentioned in the PPT. So those are the grossing details, what is there. Then it comes the grossing reporting, that we have to measure the tumor, what we are seeing actually after dissecting, how much is the tumor has spread, how it is actually differing from the DOI, that we have to keep on. But the gross description should be little elaborate, so that the surgeon also understands that we are passionate about the reporting, not just like reporting, filling up the blanks and just sending them. It is also told in the CAP protocol that you just need to write the TNM staging and just give it in the report. No need to give the description. But in my report, I do give a description why it is T4A, why it is T4B, why it is N0. So these all things add-ons to your report, so that when the person who will be giving the radiotherapy also, he will just see the report and he will see, okay, it is written like a story, nothing more to actually go back and actually dwell into that. So these are all the small things. I think people
Yes.
know much better but these are the small things which I follow.
Yes. Thank you so much. Yeah, small things do matter uh, in our pathology practice. So indeed, it was a informative session, and thank you once again all the participants and Dr. Abhishek for being a part of our study club for the third academic session of Study Club of POPMA.
Thank you. Thank
And
you.
I think we all can have a selfie. Ma'am, your mic is on mute.
I realized, yeah.
Yes, yes, yes.
Okay, I'm just activating one app which will ask you that your photo is going to be taken. Just give it permission. Let me try this new app.
I have given that.
Okay.
Yes.
Yes, perfect. Everyone done?
Thank you.
Thank
Thank you,
you.
ma'am.
Thank you so much.
It is still
Yes.
adding some photos. Okay, now I guess it's done. Yes. Okay. I'll share it with you all. But we can take one regular one also,
Yes.
just in case this doesn't work. Yeah. So let's do the regular thingy. Yes, done.
Thank you.
Thank you, ma'am.
Thank you so
Welcome.
much.
Thank you, everybody. That was a nice presentation.
Thank you. Thank you.
Thank you. And nice discussion too.
Yes.
Okay.
Okay. Okay. Bye, everyone.
Bye, ma'am.
Bye. Bye.
Bye.
Bye.
Bye.
Bye.
Bye, Dr.
Thank you.